Right, so today we're going to be talking to you guys about bipolar disorder. And to start, we'll kind of talk about what exactly bipolar disorder is. So, bipolar disorder is a mood disorder in the same category as major depressive disorder, or what most of us would call depression. And there are actually two types of bipolar disorder. Um, For this slide, I'm just going to go over a very basic outline of kind of what distinguishes the two from each other. And then after this, I will kind of explain more in depth what each of these components and types of episodes and symptoms might look or feel like. So, bipolar type 1 is characterized by manic episodes with or without depressive episodes. A manic episode or mania is going to last at least 1 week, and it could last up to several months, usually 1 to 3, but could be 6 plus if it's left untreated. And it significantly interferes with daily life, um, which can be severe up to the point of hospitalization, incarceration, or other dangerous situations. Bipolar 1 optionally can also include symptoms of psychosis. So, not in all people with bipolar 1, but in some people, either during a manic or a depressive episode, they can experience a disconnection with reality and exhibit symptoms that most of us might associate with something like schizophrenia. On the other hand, with bipolar type 2, this is characterized by both hypomanic and depressive episodes. So, to clarify, to be diagnosed with bipolar 1, you just need one manic episode. Doesn't matter if you've ever been depressed or had a depressive episode. But to be diagnosed with bipolar 2, you have to have had at least one depressive episode and at least one hypomanic episode. Hypomania is a bit different from mania. It is generally a shorter duration, at least 4 days, but up to 1 to 6 weeks if left untreated. And it generally uh, is not as intense as mania, in that it is possible to function well during a hypomanic episode, but it is also possible that the symptoms within such an episode could be disruptive to someone's daily life or relationships. And of course, what we might be more familiar with, depression, will also last at least 1 week or several months and can significantly interfere with your daily life. I want to emphasize that even though the terminology of hypomania might suggest that bipolar 2 is less severe or less difficult than bipolar 1, that is not the case, and that is not how we should be talking about the two types of bipolar. Bipolar type 2 is a completely separate diagnosis, and there is no comparison between the two for which is easier or more difficult to live with. So, as I said before, now I'll kind of get into what each of these types of episodes uh, kind of look like or feel like. I'll start with depression because that's something that in our current society is probably more familiar to most of us. Um, so, symptoms of depression include changes in appetite or sleep, feeling constantly tired or heavy, feeling hopeless, worthless, or guilty, experiencing a lack of interest in almost all activities or relationships, difficulty performing everyday activities, even getting out of bed or brushing your teeth, and suicidal ideation. And on the other end of the spectrum, mania involves uncontrollably elevated or high moods, increased irritability, decreased need for sleep, which is not insomnia or not being able to fall asleep, but being so energized that there's no need to sleep, as well as racing thoughts and speech, abnormally high confidence sex drive with a lack of social inhibitions, risk taking behavior and impulsivity, and again, suicidal ideation, which might surprise some people because we might associate suicidal ideation with sad moods. But when taking into account the risk taking behavior, impulsivity, and disorganized thoughts, these are all components that can also contribute to uh, suicidal ideation and even action. Hypomania is going to have most of the same symptoms as mania, but less intense. So, for our first discussion question, we kind of wanted to ask everyone what your understanding is of hypomania before going into this presentation. Had you ever heard of it? And maybe now after we've talked about it a little bit.
For me, I've heard of it through some courses I've taken, but also when my a close friend of mine went through um, like her first experience with learning that she had bipolar disorder, and that's when I kind of learned more about the difference between mania and hypomania. But I did like have that like misunderstanding of like hypomania being less, I guess, or bipolar 2 being not as intense as bipolar 1 because of my conception between hypomania and mania. But it was nice learning about that right now.
Yeah, I think that's pretty easy misconception. I've talked to a few of you about this, but I've had professors even who are practicing psychiatrists and neuroscientists who hold the same misconceptions that bipolar 2 is not that bad or that hypomania is not that bad, maybe even fun. And yeah, so that misconception doesn't only exist within the lay community, but even within the medical community. Um, and I think it's important that we address that.
Same here when my friend went through their uh, episode, it was pretty hard for everyone and her friends because it was her first experience with it too. And it's definitely not something to take in so lightly of or like misunderstood about. So,
For me, I wasn't aware of the existence of hypomania because when I was learning about bipolar disease, we didn't really talk about the two types. We only talked about how it's like extreme of like the two ends, and we didn't really go in depth just because it might make others feel uncomfortable. So I guess it's kind of nice to know that there's a different type and it's not less severe in symptoms, but just a different type.
Yeah, I think that's a really good way of putting it. And yeah, I think a lot of us, when we first learn about bipolar disorder, normally we think of what bipolar 1 is. Like you said, those two extremes, which, in technical terms, we call mania and depression. And yeah, a lot of people don't know about these kind of in between states, which, yeah, I like how you put that, are not necessarily less severe, more severe, but just different. All right, we'll move on. The last type of episode that I'm going to talk about is psychosis. So, like I said, this is something that can occur in individuals with bipolar type 1, not in everyone, but in some people. Um, in a depressive episode or in a manic episode, they might experience hallucinations, which could be auditory or visual. delusions of paranoia, false beliefs about being famous, having special powers, having committed a crime, and incoherent or disorganized speech. So these are all symptoms that we might not typically associate with someone with bipolar disorder. But this is definitely a characteristic that exists and something I've heard from quite a few people with bipolar type 1. This chart here, it might be a little bit overwhelming at first, but I know I threw a lot of information at you guys, and I just thought this might help synthesize some of that. I know there's a lot of lines, but I'll break it down a little bit. This y-axis is basically just a range of emotions. That's what it's depicting. Oh, Jennifer asks, does psychosis only happen in bipolar 1 individuals? By definition, yes. Psychosis is not a feature of bipolar 2. And if an individual diagnosed with bipolar type 2 did have an episode of psychosis, generally they would either be re-diagnosed to bipolar type 1 or have a separate diagnosis of something that the psychotic symptoms can be attributed to. But good question. As I was saying, this axis is representing a range of emotions, and at the lowest point is clinical depression, and at the highest point is clinical mania. And if we look at this red line, that's going to represent basically the mood of an average person over a series of weeks or months. And we can see if we follow this, an average person mood fluctuates a bit over the weeks, but they're generally pretty happy during this period of time and then a bit sad during this period of time. But throughout this whole, uh, you know, we'll say few months, few weeks, none of these emotions or moods are disrupting their daily life. This sadness or disappointment is not preventing them from going to work or going to school or, you know, managing their hygiene. On the other hand, if we look at the yellow line, this diagram calls this unipolar depression. That's what most of us would just call depression or major depressive disorder. And you can see that this person experiences, mostly the same positive emotions, pretty average positive emotions compared to the average person. But right about here, they experience a depressive episode. And I think it's really important to distinguish that the depth of this low mood is far below the depth of an average person's lowest mood. And so depression is not just being sad, it is something much more profound than sadness. And it is something that someone who has never experienced depression cannot fully understand or relate to because it is beyond their own range of emotions. And that, I think, is something all of us should keep in mind. When we look at this blue-purple line that represents bipolar 1, so you can see this person straight away enters into a depressive episode, which looks exactly the same as a person with depression. But then right after that, they head into a manic episode. And as you see, again, this high of emotion is far above the highest point in emotion of an average person. And this might get redundant, but I'll reiterate that this is much more profound than being hyper or excited. And it is not something that an average person can fully comprehend, or even a person with depression or a person with bipolar 2 can fully comprehend, because none of those people have experienced this height or range of emotion. And after that, they do enter a period of a normal range of emotions, which is common, that a person might go months, even years without an episode. The green line is bipolar II. You see, again, this depressive episode. You might notice that this is a longer depressive episode than the bipolar I individual. That's pretty common in bipolar II for individuals to experience longer depressive episodes than a person with bipolar I. And then after that, they enter into a hypomanic episode that lasts greater than 4 days, which it might not seem much higher than the highest point in an average person's range of emotions. But even if it doesn't seem as extreme compared to mania or compared to depression, that difference is still something, again, I'll say, that is profound and cannot be fully understood by someone who hasn't experienced it themselves. And I think that's important for our group when, or anybody, when we might judge someone or think about someone who is going through something that we've never experienced, um, to recognize that limitation in our own experience. Oh, I wanted to ask if anyone had any questions after that.
Um, does mania always follow depression as quickly as like represented by the graph? Is it going to be like within like it looks about like a 4 day span, or does it vary by a lot of time?
Yeah, that is very variable. It is actually more common for a person with bipolar I to have a manic episode followed very quickly by a depressive episode, but they can also happen completely separate from each other, separated by months, years, even decades. Um, yeah, so this is just an example to show both, I guess, both ranges on a single graph, but it definitely doesn't have to happen in this order or in this sequential nature.
Previously, you said that people with bipolar I disorder might not experience depression or
Yes.
um
Yeah, so in this
so
example, oh, go ahead, go ahead.
so if they're going through only manic episodes, how do you know that they're experiencing bipolar? Does that make sense?
Yes, yeah, definitely. I think we know from, like, we think about the name bipolar, we think of the two ends of the spectrum of emotion, right? But just, medically, the definition of bipolar I is about the mania because we don't have any other diagnosis for someone with mania. So that's really the defining feature of bipolar I. And most people that have experienced mania have also had a depressive episode and experienced depression. You don't find a lot of people that are diagnosed just with a manic episode, but that's all that's required for diagnosis, if that makes sense. Wendy asks, is this an imbalance of neurotransmitters that causes such extreme shifts? So a lot of the psychiatry is a really interesting field in that it's very atypical in the medical field. We don't understand a lot about how the brain works, and we don't understand a lot about how mental illnesses work or medication work. And so there are theories about bipolar disorder, that there's an imbalance in norepinephrine uh, levels, um, but none of the theories can really explain both ends of the spectrum. Um, so they do believe that there may be hyperactivity of neurons in the brain and norepinephrine in the brain, that's causing excitability, but it doesn't exactly explain why depression accompanies the mania or hypomania. No problem. Any other questions? Okay, we'll move on.
So I'm going to be talking about the prevalence of bipolar disorder. So it's the second most common mood disorder following major depressive disorder. I purposely didn't include statistics on the difference between bipolar disorder 1 and 2 because the literature is a little bit wonky in the sense that some studies say one is more prevalent and the other is more prevalent. So it's a little difficult to generalize. And so it affects 4.4% of US adults at some point in their lives. And it is one of the most highly heritable disorders, and it's even higher than something like breast cancer. And so a 2003 study showed that there was a 60 to 85% heritable risk if your relatives or somebody that you were related to um, had bipolar disorder. And then of those diagnosed with bipolar disorder, 82.9% reported severe symptoms. And some studies have cited that there have been higher diagnoses in females and males, but it's a little bit convoluted as well. And so I wanted to show this graph here showing the prevalence of bipolar in 2001 and 2003. It's a little outdated, but it was from the NIH. Um, and I wanted to highlight this middle bar here. Um, thank you, Zoe. um, the 18 to 29 age range has the highest prevalence of bipolar disorder. And I think that's very jarring to really see. Um, And also keep in mind that the diagnosis of bipolar disorder is, and obviously every other mental disorder can be underdiagnosed or be confused with another mental illness. And so these are percentages that are tentatively reported. And it's important to keep in mind that these might be higher than they actually are. Next slide. And then I'm going to be talking about treatments. So for treatment, one of the main ones is medications, and those are known as mood stabilizers. And so one of the most commonly used ones for especially bipolar 1 is for lithium. This might be kind of weird, but yeah, so it requires a lot of monitoring because lithium can get dangerously high in your blood, and that can cause potentially death. And so those that have bipolar disorder that are taking lithium, they have to go in for um, maybe daily checks to check on their blood levels to see if the lithium levels are safe levels. And then it's known to reduce suicide risk by 50%, so it has a good amount of efficacy. And the second type used is anticonvulsants. These are known as nervous system kind of depressants. And so it's sort of helping to control the excitability of neurons in your brain. The third one is antipsychotic medications. Those are to combat those psychosis episodes that Zoe talked about, and antidepressants to combat depressive episodes. Or so these medications are kind of geared towards whichever symptoms that you are experiencing as a bipolar patient. And then the second one is psychotherapy as well. So CBT, just common psychotherapies. And these are supposed to manage interpersonal occupational relationships. It gives psychoeducation, so kind of understanding your diagnosis and understanding how it's going to influence your life. And the last one is family therapy. And so this is supposed to teach you how to support a loved one if they're diagnosed with bipolar disorder. And that's really important because social support is a um, key factor in increasing your uh, uh, healability rate, I guess. And another more invasive technique is electroconvulsive therapy. And so, if you guys have exposure in the coursework, it commonly looks like there's a bunch of wires on someone's head. And These are typically for medication-resistant bipolar diagnoses, and what it kind of does is give the brain a brief seizure, and it's supposed to be a depressant of the brain as well. So that's a little bit of a more invasive technique. And then just to point out, all these treatments are applied on bipolar patients, but the mechanisms are really unclear. And as Zoe previously said, the literature on bipolar disorder is and other mental illnesses, in fact, are limited, and our understanding of mental illnesses is also very limited. And so we kind of just use these treatments because we know they are effective, but we do not understand the mechanism so much.
Now to switch over and start talking about how we can raise awareness for bipolar disorder. I know here at Pup Support, we all know the importance of raising awareness, and one of the ways we can achieve this is through education and discourse. And, one of the things we're always going to be advocating for with mental health and mental health disorders is going to be that deconstruction of stigma. So let's talk about stigmatization of bipolar disorder. And I'll start off with a discussion question for you guys. Are you familiar with stigmas commonly associated with bipolar disorder? If you want, you can type some out in the chat or you can shout them out, but it would be really great to hear from you guys, again, pushing for that discourse and conversation that's so crucial to our education.
For bipolar disorder, I think I've heard something like they have like extreme mood swings. So like talking to them, you have to be really careful about what you say.
Right, like walking on eggshells. Yeah, that's a definitely very common one. I see some people
I think
typing in the chat. So, oh, sorry, was someone gonna say something?
I was gonna say something.
Oh, go for it.
I guess like that one time my friend kept talking about how her bipolar grandma was either crazy AF or just like in terms of not wanting to talk to anyone and like being like shut up in their room or just going out and gambling all her stuff. I think like that was kind of a stigmatization that she was like perceiving her grandma that kind of way.
For sure. Yeah. And, like when you use those terms like crazy, I think that's going to tie into a lot of what's on the next slide when we talk about how the term bipolar is used in mainstream language. So that's really good input. And I see Robin in the chat, she said, I'm not sure if this counts as a stigma, but the word is commonly weaponized against people who exhibit intense emotions, what Wendy is saying, and it is harmful for people actually diagnosed with it. Yes, very true. And yeah, Robin, that totally adds on to the stigma. So I agree with you. Again, when we start kind of diving into that term bipolar and language, we'll definitely touch on these, I guess, notions of weaponizing language, especially in the field of mental health. So yeah, thank you so much for participating, guys. Really good input from everyone. And I just listed some stigmas here, and a lot of it actually overlaps with your guys' input too. So again, there's so much more, but here are some I'd like to share with you guys. So for one may ignorantly fear and ostracize those with bipolar disorder, believing they are quote unquote dangerous and violent. And I think a lot of things contribute to this stigma, even in our media, our movies, TV. Historically, people have unfortunately believed individuals with bipolar disorder who can experience episodes of psychosis to be quote unquote, unhinged or psychotic or crazy, just like those words you guys were just talking about. And yeah, just like Robin and everyone else said, these are really harmful associations, and it's what result in people believing that individuals with bipolar disorder could be seen as a threat or a danger to society, quote unquote. So that's a big one. Another one may ignorantly believe that bipolar disorder is just comprised of mood swings. So I think, was it Jennifer who brought this up? But yeah, someone had brought this up earlier, and exactly that. And I included this one because when I was thinking about it, I was just kind of thinking, well, I feel that for those who might not ostracize these individuals on the basis of fear, it's usually just through pure ignorance instead. And that ignorance is rooted in not understanding the diagnosis of bipolar. And just like, Zoe and Christine gave really, really educational talks on these diagnoses, there's so much more than just mood swings and shifts. These individuals can experience those periods, long durations of time in a mood shift, years and decades, and to undermine their experiences is truly unacceptable and harmful because it not only reduces the disorder but also reduces those who live with it. And lastly, even within the disorder itself, there can be stigmatization in the types, and I think we had a really healthy conversation about this earlier in our presentation. A lot of us were learning about bipolar I versus bipolar II, and I actually wasn't familiar with that either until I started, doing my research and having conversations about it. And it is true that some people may believe bipolar I to be a quote unquote less serious or less severe version, or sorry, bipolar II to be a quote unquote less serious or less severe version of bipolar I. But we know this is not true, so we're reiterating a lot of what Zoe said. Bipolar II is a completely separate diagnosis, and it is not a subtype of bipolar I. And as we learned from that really helpful graph earlier, those with bipolar II can experience hypomania. And remember that these periods of hypomania, they don't reach like that peak mania. With this understanding, Zoe had actually brought up a story earlier about how some of her professors have very inappropriately said and may have believed these episodes of hypomania to be quote unquote fun or maybe even enjoyable. That wasn't the first time I heard that story, but I do remember the first time hearing it, and I was really shocked and really offended. Even though I am not living with bipolar disorder, I just again think that undermining and this constant reduction of the disorder and those who live with it is unacceptable. So we do need to continue to actively learn and educate those around us. So we've sort of talked about how some of these things feed into the stigmatization. Again, our media, our movies, our TV. And really, how is this term bipolar used in mainstream language? So I think we have all heard this term to be used to describe a person whose mood can change constantly and quickly, going back to that whole mood swings thing. This is another reminder that the moodiness or the mood swings that someone may experience, that is not what constitutes a diagnosis of bipolar disorder. Again, these individuals, they can experience these mood shifts for months or years on end. It's not just a simple bad day. And looking back at the graph that Zoe had showed us, when she talked us through it, you could see again that the hypomania and the mania, it was just far above the threshold of the range of emotions of an average person. So that's a really big takeaway from this presentation. And another thing I'd like to note is there, of course, with a lot of mental health disorders, there's always going to be this implication of self-diagnosis. So this actually kind of wraps around to our previous presentation on self-diagnosis and self-advocacy for those of you who were there. Experiencing the occasional mood swing, it does not warrant a self-diagnosis of bipolar disorder, just as experiencing a few hours of hyperactivity is not synonymous with a manic episode either. So it's really important for individuals who are truly concerned that they may be living with this disorder to seek help from a licensed mental health professional. And again, like really taking the action to educate themselves and potentially receive a formal diagnosis. All of this and sort of trying to reduce the amount of self-diagnosis that goes around, like all of this can be just one step towards demolishing the stigma and advocating for yourself. And on the next slide, we just have some really helpful resources. So I believe the first two are from NAMI. We love NAMI. There's also, for those of you who are interested, more information on bipolar I versus bipolar II, and these resources are also going to go into way more detail than we did. I also included some links of personal stories for those who are living with bipolar disorder. This is from the NAMI website, and I just thought it would be nice if you guys have the time or if you guys have further interest to really read those stories and hear these experiences in their own voices, basically. And the last two links, there's a link to the Depression and Bipolar Support Alliance organization. They're a nonprofit, patient-run organization, really big, and they work to support and educate those about depression and bipolar disorder. And the very last one is actually a link to a NAMI bipolar support group based here in Seattle. And it's just, I think it's just like a meetup link. But if you guys know anyone who's interested in learning more, or if you want to like self-edify, this would be really awesome. So yeah, thank you for listening to our presentation, guys. And if you guys want to have a conversation, we totally can. If you have questions, we can try our best to answer them. So yeah, thank you.